Hi, good evening. I'm Dr. Punyajit Valgampaya. I will be the moderator this evening. On behalf of College of General Practitioners Sri Lanka and its CPD committee, I would like to warmly welcome you all to this very important webinar on Chikungunya. Before I introduce the guest speaker for this evening, I would like to request everyone to switch off their mics. Also, kindly post your questions on the chat so that I can get the answers to your questions at the end of the lecture. Thank you. The guest speaker for today's webinar on Chikungunya is Dr. Meneka Ranaweera. Dr. Meneka obtained her MBBS from London School of Medicine. She obtained a postgraduate certificate in medical education from the Postgraduate Institute of Medicine, University of Colombo, Sri Lanka. Then she went on to obtain a postgraduate diploma in medical virology from Postgraduate Institute of Medicine, University of Colombo, Sri Lanka. She then obtained a master's in medical education from the University of Dundee, UK. Over to you, Dr. Meneka.
Thank you, Dr. Punyajit. So can you hear me?
Yes, we can hear you clearly.
Excellent. Let me try and share my screen. Is that okay?
Yes, we can see it clearly. You can go ahead.
And can you see my slide?
Yes, we can. Yes.
Brilliant. Thanks so much. So good evening, everyone. Firstly, thank you to the College of General Practitioners for inviting me for this webinar. I'm Meneka Ranaweera, currently working at Royal Free Hospital in the UK. So today we will be exploring this very interesting virus, Chikungunya, and I'm very excited to be here and share my enthusiasm with all of you. So if you do have any questions, please raise your hand and Dr. Punyajit will pick that up, or you can, as he mentioned, put it in the chat and we can have a discussion at the end as well. So what I'm hoping that we could cover during this webinar is regarding the epidemiology and clinical spectrum of chikungunya, and to identify some key diagnostic features and how we can distinguish it from chikungunya from other viral illnesses. And we will also focus a bit on the current management strategies and see how we can apply this knowledge to improve patient care. So, first of all, let's look at our virus. So, chikungunya belongs to the alpha virus genus of the family Togaviridae. It's an enveloped single-stranded RNA virus. Now, you might ask, why is this information important to us? So there are several ways you can look at it. So chikungunya belonging to the Togaviridae family is quite critical information because it can help us down the line. So clinically, this is very similar to dengue, which belongs to the Flaviviridae family. So one of the questions we might have is, could there be cross-reactivity when we are thinking of diagnostic tests? But knowing that these are completely different families, we know that is unlikely. And the fact that it is an RNA virus means that we can anticipate certain amount of mutations in this virus as it continues to replicate. This is because it has this RNA polymerase enzyme, which is involved in the replication, which is not very accurate, and it is prone to making mistakes. So what this could mean to us is that along with with time, we might notice that there can be changes to the clinical spectrum, or we might find that our diagnostic assays are no longer able to pick up this virus anymore because it has mutated. Or down the line, if there are antivirals, we might find that they no longer work. Or any vaccines we develop no longer work because the virus has mutated. So this means that we need to be more vigilant and monitor exactly what happens to this virus. And knowing that this is an enveloped virus, enveloped RNA virus, we can anticipate that it is not quite stable and is able to live outside of humans or mosquitoes. And it also means that we can anticipate that we can inactivate it easily with heat and alcohol-based disinfectants. So as I mentioned, when we are thinking of the mutations that it's happened, so now we've got 3 genotypes: West African, East Central South African, and there is the sublineage Indian Ocean and the Asian genotype. So 3 main genotypes, and there is talk whether Indian Ocean, this particular lineage, sublineage, whether it can be considered a genotype on its own right because of the mutations that is undergone. Okay, let's now focus a bit on this interesting story of chikungunya, how it has spread over the years. So we think that the virus emerged as a human pathogen around 400 to 500 years ago. And there have been cases reported where, cases described rather, which could be chikungunya, but we can't quite prove it. But it was first described in 1952 in Tanzania, which is quite an interesting story. So in a very small village where dengue was rarely reported, they identified a condition which was very similar to dengue. And what was more interesting was that within a few weeks, 60 to 80% of the population developed this illness. And at that time, it was the symptoms were again characterized with a rapid onset of fever, with frighteningly intense joint pain that was immobilizing. Fever that the fever pattern was that usually had about 1 to 6 days of fever, and then 1 to 3 days of no fever, and then a secondary rise in fever. And there was maculopapular rash all over the trunk and extensive surface of limbs, which coincided with the secondary fever spike. And this occurred in about 80% of the patients. They also had noticed no one was reinfected. So it's interesting whether these kind of symptoms is what we are experiencing at the moment, or there are subtle changes. It took another couple of years before the viral etiology could be confirmed through isolation from both the patient blood as well as mosquitoes. And this took another couple of years for isolation to occur. Then following that time, until about 2004, there weren't any large outbreaks. So there was the spread to Asia, and then sporadic cases were occurring in Africa as well. But then in 2004, things changed. So this genetically, we can coincide this with a certain mutation that occurred, which enabled the virus to be better able to adapt to Aedes albopicus. Whereas earlier it was more just Aedes aegypti that was the main culprit in carrying this virus. Then, of course, around following the re-emergence in Kenya, then we saw it moving to Indian Ocean region, then to Europe, and as well as Southeast Asia. And this was the time that we had our major outbreak as well in Sri Lanka. And then on the other side, we had starting from the Caribbean islands, virus entered the Americas, we had still a significant problem in South America.
Excuse
And
me,
the
Dr.
current status, the virus transmission is now reported in over 100 countries worldwide.
Excuse me, Dr. Meneka.
Yeah.
Is it possible for you to enlarge the slides a little bit? It's not very clear, please. That's fine.
Can you see my slide now or the presenter view?
Now fine. Now that's fine. Yeah. Yes, it's fine now. Now it's okay. Yes.
Is this still okay?
Now it went back to the previous state.
So, but you seem to continue earlier.
Yes. If you can, and yes, that's fine. Now it's okay. Yes. Can keep it like that. Yeah.
So, in terms of the global situation, we have a map here showing the spread of cases from June 2024 to May 2025. You can see here that India and Brazil are having a large number of cases. But if you look at the individual numbers from 2025, the total number of cases is 220,000, with deaths occurring around related to chikungunya around 80, or from 14 countries. And if we look at the Sri Lankan situation, so these are this data from the Epidemiology situation report from June. So the greatest number of cases have been reported from Colombo district, and the sequencing data have confirmed that this is Indian Ocean lineage, and there is a preponderance for females, with 55.1% reported among females. Okay, so let's look at some of the possible routes of transmission. So let's consider this family and see if this is chikungunya in terms of how it's spreading. So first, we've got a 36-year-old male who has developed low-grade fever with wrist stiffness. Initially thought it was stress, and however, there was a fever spike the next day, and the joint pain became severe. In fact, was struggling to even hold a pen. Then 3 days later, we've got the mother, who's 74-year-old, who fell ill, but her condition is much worse, with swollen ankles, severe calf pain, unable to even walk without a support, and fever lasting for nearly a week. Then we've got 31-week pregnant wife who's got high-grade fever, rash over arms and chest, and joint pain and extreme fatigue. Then a few days later, the son develops. However, his symptoms recovers quite quickly. So, can we expect this kind of spread? and transmission. So to answer that, we need to consider about the route of transmission. So it is mainly through Aedes aegypti and Aedes albopicus. If there is common breeding site, then definitely we see these kind of things where several members of the household develop the infection. It's not necessarily sequentially infecting one person to the other. And other routes that we need to consider include bloodborne. So there has been reports of laboratory and healthcare exposures. However, there hasn't been any reported cases from organ transplant or blood transfusions, although that is a theoretical possibility. Because I suppose in a way, like chikungunya seems to be very symptomatic condition. So if you're that unwell, you're hardly likely to be going and donating blood. Then the other important route of transmission is mother to child. This is of course described as well, which can occur in utero as well as intrapartum, especially if the mother is viremic near delivery. No reports of breastfeeding being a problem. So let's look at some of the clinical features. So this is again, this is something I have taken straight from the national guidelines. So initially we have the described as in 3 phases, depending on the duration of symptoms. So acute phase lasting up to about 2 weeks, and the chronic phase is when symptoms persist for more than 3 months, and the in-between period is the subacute phase. And in the acute phase is further divided into the febrile stage and the arthritic stage. So febrile stage, mainstay of symptoms, sudden onset of high-grade fever, severe arthralgia or arthritis, rash, and certain proportion can be asymptomatic as well. In the arthritic phase, one of the important things to note is some of the joints, small joints tends to be involved a lot. Multiple joint involvement is seen as well. And along with that, you may experience some other symptoms like myalgia, headache, oral ulcers, neuropathic pain, abdominal pain, diarrhea, vomiting. Those are all described as well. And the subacute and the chronic phase, these are categorized according to the persistence of symptoms. So apart from these symptoms, does chikungunya affect other organs? Yes, it does. And it is not very common though, but some of the things to look out for are encephalitis. So is there any CNS involvement in your patient, any confusion? So these are things to tell your patient when you are safety netting. Then any visual symptoms, again, something you can ask for and check for. So now you are going to be seeing a lot of patients with chikungunya coming to you. So who are the ones that you need to be more careful about, who you think might benefit from hospital admission, or you want to follow up more closely? So some of the high-risk categories are pregnant women, infants less than 1 year, and adults over 65 years, and those with comorbidities. So one of the diagnostic challenges is whether this is chikungunya or it could be something else like dengue, which is currently circulating as well. I have only focused on these 2 because these are the 2 common viral febrile illnesses that is present in Sri Lanka, whereas there are quite others in certain areas as well. Unfortunately, these 2 viruses are not antagonistic, so co-infection can also happen, both in humans as well as mosquitoes. So we need to be able to identify. So some of the main things, so chikungunya, the hallmark feature being intense joint pain, whereas that is not so common in dengue, whereas it's myalgia is more common. And chikungunya is associated with sudden onset of fever. Skin rash is common in both cases. There is less of a tendency of bleeding or other organ involvement in chikungunya compared to dengue. And although we may see a drop in platelet count, it's likely to be much worse in dengue. And the chronic sequelae is much more common in chikungunya than dengue. Okay, let's move on to laboratory diagnostics. So let's look at this case. And so we've got a 24-year-old university student who is living in a boarding house in Colombo who presents with fever, severe joint pains in wrists and ankles, and difficulty walking due to stiffness. And he mentions 4 of his mates have similar symptoms, they thought, which has been diagnosed as chikungunya. So he went and got a test done right away. So we've got a test which is negative for chikungunya, IgM and IgG. So how do we interpret this? So in order to do that, we need to have a really good understanding of the viral kinetics, how the virus behaves, and also the immune response that the body is able to mount. So here in the x-axis, we have the time in days. So day 0 is when the symptoms are starting. And we have the incubation period here, so around, which ranges to about typically 3 to 7 days, but can range to 1 to 12 days. So from the mosquito bite to symptom onset. So you can see viremia starts a bit earlier than that, and then it lasts about 7 days. Then our immune response, IgM, and IgG, so they take a bit of time to develop, although it starts to develop around day 4, day 5. Substantial rise can be seen around day 7, and it lasts for about 1 to 3 months, whereas IgG tends to rise around day 7, and then it tends to stay for a long time, elevated for a long time. So a couple of important things to note. So if we are using tests that is able to detect the virus in blood, so the timing of the testing has to be within 7 days. The earlier the better, because as you can see, it will decline with time. So things like culture, antigen, PCR, so these are the things that we are thinking about when we are trying to detect the virus. And the serology is recommended after around day 7 so that there is the greatest chance of being able to pick up these responses. And the other thing is that it's important to note that IgM persists for quite some time. So just in case if it is positive, it does not mean that it's an acute infection. And IgG, as I mentioned, lasts for a long time, so it can indicate past infection. So what about our chap with that very, very suspicious report? Well, it's not reliable at all because it was taken on day 2, so we cannot rule out chikungunya based on that. So let's just look at some of the others testing. So when we have clinical suspicion, there is of course the basic laboratory test which can support diagnosis. So what has been noted is leukopenia with high lymphocytes, thrombocytopenia, raised ESR and CRP, and kidney and liver function. There may be alterations based on if the organ involvement is there. And the mainstay of the testing is really PCR and serology, although there are other available tests for detecting chikungunya in a clinical setting. PCR is what is preferred, and has a greater sensitivity. It can be tested in blood as well as CSF if you're suspecting sort of a neurological involvement. And in terms of blood, you have to liaise with your local lab in terms of what kind of a specimen that they would accept. And again, serology, as I mentioned, it is best done after 7 days. And then we have further testing. This is more for public health and research context, not really for diagnostic purposes, sequencing and genotyping. As I mentioned earlier, Chikungunya is an RNA virus which has quite a lot of mutations can occur, so it's important that we monitor them, whether there has been sufficient changes, whether there are certain mutations, because this can then be used to correlate with clinical symptoms to see if there has been any changes, and can also inform certain public health strategies as well. So if we look at the management, this is again a summary taken from the national guidelines, which gives a management according to the different phase. Now, you have a huge role to play here, because as many patients are going to be coming to you, and you are in a position to provide the most impact for these patients. Because sometimes it's not about the treatment you can prescribe, but it's the time you take to reassure the patient and provide the correct advice and supportive measures. So you can make a huge difference. And the thing with Chikungunya is that though mortality is not high, it is very debilitating. Patients find the pain and the immobility distressing and very frightening. So providing the correct advice in the initial stage about the course of illness, need for rest, fluids, and regular painkillers is vital. So if we look at according to the stage, so initial stage, it's about regular paracetamol, encouraging fluid intake, resting and limiting activity, and avoiding NSAIDs and steroids at this stage. Then increasing in with pain management when you've got further joint pain. Again, at this stage, again, steroids are avoided. And then when you're heading into sort of the subacute arthritic phase, steroid is recommended at this point. And if you head to chronic phase, then the recommendation is for referring to rheumatology for further treatment. Are there any antivirals? So this is, of course, a subject that is of very great interest to me. Unfortunately not. So there are a lot of candidates that have been considered, and there are ones who are already in use for other purposes, such as ribavirin, favipiravir, soluble, but none of these are in sort of clinical trials which can, or promising, or some things that are going to be available soon. So unfortunately, no antivirals at the moment, and nothing in the horizon in immediate future either. So we have to rely on our supportive measures. So prevention, what can we do for prevention? So here is another area where you have such an important role in how you advise your patients, what kind of health promotion and education you build into your routine practice. So this is again about a combined approach, eliminating mosquito breeding sites, personal protection to avoid mosquito bites, rapid case detection, and community engagement, and if traveling to area of endemic, so I suppose it's depends on where you are traveling from. Certain precautions are possible. And vaccines, there are a couple of vaccines that are available. There is a live attenuated vaccine that is approved and is currently in use in United States, Canada, UK, and Europe. However, recently there have been some side effects that have been reported, including fatalities, but these are not directly related to the virus as such because this is still under investigation. So a caution had been issued regarding its use in individuals over 60 or 65 years. And there is another virus-like particle vaccine which is approved and used in USA. However, neither of these vaccines are approved by WHO, but WHO is so having an ongoing review of the vaccine, so it might be available depending on what they say. In terms of prognosis, so very low case fatality rate, which is very reassuring, but very high chronic or permanent disability. Okay, so that brings us to the close of the session. So before I allow any questions, I have a question for all of you. I am curious to know and would love if you could share in the chat, or you could unmute and share as well as today's discussion sparked. Any ideas about how you might approach or manage these patients differently in the future? We'll give a few minutes. So thank you, and happy to have any questions if there are any.
Yes, Dr. Meneka, there are a few questions. The first one being, how long after being infected with chikungunya can a patient donate blood?
I think in this situation, it might be better to check for the. So I'm getting a lot of echo. Can you hear me clearly?
Yes, we can.
Okay. So I think it might be better to check with the national blood bank because there may be certain differences in different places. Generally, once the viremia is settled, it would not be a problem. But to be honest, I'm not exactly sure of the exact timing in different countries.
Okay. So which segment of the population can the chikungunya vaccine be given? Does it have any protective effect against dengue?
So the two vaccines that have been in play, both are actually not going to provide any protection against dengue. Because as I mentioned, there are two different families. There is some cross-protectivity for certain other viruses, but it won't be for dengue. And to whom it can be given, the virus-like particle vaccine that is actually being recommended for over 12 years. But this is still too early because at the moment, how it's being used is the countries where people are going to be traveling to endemic countries, they are being recommended the vaccine. But I can't see, I don't know if that it being used in places where Chikungunya is endemic. So we have to wait for the WHO recommendations as well. And I think there is a position paper that is due to come out next year regarding this as well. So that might provide us some more information on this.
Also, how the reinfection with chikungunya, and is reinfection is arthritis more severe?
So generally, you wouldn't consider there to be infection with chikungunya. What is expected, what is believed to happen is that there will be lifelong immunity. But I'm not sure of any sort of like individual cases that may have been reported which has reinfection. So generally what we can say is that reinfection generally is not anticipated. So then it becomes difficult to comment on whether arthritis is more severe because we don't generally have a lot of data of cases or scenarios where reinfection is commonly reported.
Is it possible to give DMRDS instead of prednisolone for reducing joint pain in subacute phase, although the guidelines have mentioned it is to be used in chronic phase only?
Oh, I'm really sorry about this. This is completely outside of my expertise, so unfortunately, I don't think I can provide an accurate answer for this one.
Is there any difference in the full blood count between chikungunya and dengue?
Yeah, so dengue, the level of sometimes thrombocytopenia that you would expect may be greater with dengue. And there may also be a difference in MBBS in dengue, which you wouldn't expect in chikungunya. And there may be associated neutropenia as well, and that you can see in dengue. But I do suggest, I mean, it's sometimes very difficult to go by that full blood count. If you are really like clinically thinking that this could be either, or if you think co-infection can happen, then it's confirmatory testing that can help definitely. That will answer this question.
Are there any food that can aggravate chikungunya arthralgia?
Not to my knowledge. I haven't extensively looked at it, but what I have seen, I'm not aware of it. I'm not aware that there are certain food that is known to aggravate and is recommended not to take. So.
Right. So that's about it. I think, yeah. So in the absence of any more questions, on behalf of the College of Gender Practitioners Sri Lanka and its CPD committee, thank you very much, Dr. Meneka Ranaweera, for taking your valuable time all the way from UK to do this CME. We also want to thank all the participants as well. Thank you very much and have a good night. Thank you so much.